Hey, I can't believe that you guys are back again to learn more about advanced concepts in screening of disease. Well, welcome to this session. We are going to talk about the advanced concepts which are predominantly which will be based on the understanding that you have built in the first and the second session. Let's move ahead and let's talk about the screening and the diagnostic tools. You already know, just to appraise you, just to brief you, that you're not nothing new. I'm not new. We've already talked on this, that there's true positive, there's true negative, there's false positive, and we have a false negative. You already have talked about the rules. You always should remember D plus is here, D minus is there. So test negative and you have a test positive. I think this table must be super easy for you. So now let's get going and let's talk about what is a screening tool and what is a diagnostic tools. Please remember that what is the formula for false positive error rate? False positive error rate is given by the formula false positive divided by the total disease minus. What is the formula for false negative error rate? False negative is false negative divided by the total disease plus. Please also remember, I don't know how will you remember, but I have remembered it as P. P is my favorite alphabet in PSM. So I like P a lot. I don't like the word P, but the alphabet P. So P in FPER, it means P. It is also in Hindi, we call it as the Pehla error. So it is somewhat related to type 1. It is related to type 1 error. It is also related to the Pehla alphabet in Greek language, that is the alpha error. So that's how I have remembered, whatever way you want. In Hindi, we say FPER. P stands for Pehla. So Pehla error or type 1 error. FNER obviously would mean a beta error or a type 2 error. So mind you, I'm not saying that type 2 error is nothing but a false negative error rate. It is the concept of type 2 errors and the concept of false negative error rate is same. The concept of alpha errors or type 1 errors and the concept of false positive errors is same. The concept is same. Okay. Which error, MCQ now, which error is more important or more serious? We say that as far as seriousness of an error is concerned, which error is more important? To leave a diseased person and to label him healthy, that is bad, or to label a healthy person as diseased, that is bad. What do you think? I know many of you must be saying that, sir, leaving a disease is always bad. We always should get people. I know you are a doctor by heart and that's what brings the answer from within you. But from public health perspective, please remember that the serious error is always the false positive error. The false positive error will always be more serious than the false negative error. Please remember this. In other words, type 1 errors are more serious than type 2 errors. In other words, alpha errors are more serious than the beta errors. So remember, for the seriousness of disease, false positives are more important than false negative. Many of you must be stuck at this first point only, that sir is talking left and right. Why is he saying like this? Please remember, let us say a 50-year-old male enters into our OPD. 50-year-old male enters into our OPD with some chest pain. And you do an ECG and the ECG will show some of the ST elevations. If the ECG shows ST elevation, will you label this patient as MI and start the treatment right away and thrombolize the patient? Answer is no. We should confirm using some cardiac enzymes, using the TROP-T or something CPKMB or cardiac enzymes you are going to assess. Why on earth would you assess for cardiac enzymes when the ECG is already showing changes? You are going to check cardiac enzymes. In the subconscious mind, your mind said, do cardiac enzymes. Why? We are doing cardiac enzymes. What if this ECG is what? False positive. Are you understanding? What if this ECG is false positive? So try understanding that all the time we are using some higher tests which have lower what? They have lower false positive. If they have lower false positive, that means higher what? Sensitivity or specificity? You remember from the previous session, answer is have higher specificity. They will have higher specificity. Therefore, whenever we are confirming that yes, this is the person with disease or there is a disease in this person, you should have a test which has lower false positivity. In layman words, we say specific test. That is the take-home message for you. Please remember what is a sensitivity or a screening tool. For screening of diseases where we are doing preliminary test or the initial test, we always talk of false negativity. In layman terms, we also talk of increased sensitivity. Please remember, use a sensitivity whenever we talk of screening test, but whenever we talk of diagnostic test, in diagnostic test, we are going to use specificity. So that is your MCQ number 1. Diagnostic test specificity, screening test is sensitivity. False positive error rate is more serious than false negative error rate. First MCQ. Second MCQ. What do you mean by the likelihood ratios? That is your question number 2, topic number 2. What do you mean by likelihood ratios? Likely means likely. Likely means something which is going to happen. So please try to understand that likely means what? Likely means the chance of having a disease. So chance of having a disease is called as likelihood. Mark it in bold words. If you do a mistake later on, don't say that sir did not emphasize that chance of having a disease is called as likelihood. Don't say that. Mark it. You will be doing a mistake because you are not marking it bold in your copies. Chance of having a disease is called as likelihood. Let us calculate the likelihood now. If you want to calculate the likelihood, please let us say that there is a table like this. There is a true positive, there is a true negative. There is a false positive and a false negative. This is D plus, this is D minus, test plus and test minus. What is the likelihood of having a disease? Likelihood ratio. Likelihood of having a disease if the test was positive. Can you tell me the answer? Likelihood of having a disease if the test was positive. So likelihood of having a disease if the test was positive. Which one is the positive test? The positive test is this one which I have highlighted in red color. So what is the chance of having disease if the test is positive? Expressed in what? Expressed in ratios. Why? Because there is a likelihood ratio. So don't give me the answer that it is true positive, that is chance of having disease, out of total tested positive. Do not give me this answer. This is unfortunately a wrong answer, because what is this? This is a positive predictive value. It is a proportion. I am saying tell me the likelihood in terms of ratio. The likelihood of having disease if the test is positive. The likelihood of having disease if the test is positive will be given by the formula true positive divided by false positive. That is what is the likelihood ratio. True positive divided by false positive, right? So now if this is true positive divided by false positive in correlational terms, you remember in the last video, in the last module, we had correlated this. You had correlated with what? This is sensitivity, this specificity, 1 minus specificity, 1 minus sensitivity. You had correlated that. So can I say that with this, using this correlation formula, can I say that the likelihood ratio for a positive test can be written as the sensitivity divided by 1 minus specificity? Am I correct? Technically, this is the formula for likelihood ratio positive. Please remember that this is the formula for likelihood ratio positive. Do not mark it as TP by FP. This is just a point for you to explain. Forget it now. Are you understanding? That was just to build you the concept that how are you going to get this formula? How do you derive this formula of sensitivity by 1 minus specificity? It pertains to this understanding. Can you tell me, if you have understood this, now can you tell me what is the formula for likelihood ratio in a negative test? You tell me now. What is the likelihood ratio in a negative test? Please tell me. What do you think? Likelihood ratio for a negative test, will it be Tn divided by Fn? If you are saying this, you are wrong. You have forgotten what I told you over here, that you will do a mistake, chance of having a disease. So chance of having a disease, that means what? That means the answer should be false negative over true negative. Are you understand? Don't even give me this answer that it is true negative over total tested negative. What is this? This is actually a negative predictive value, which is a proportion. So don't talk of these all things. These are proportions. So what is the answer over here? What is the likelihood ratio negative? It is given by the formula false negative divided by true negative, and this is the formula. Now go to the correlation word. Correlating them, you are going to get what? False negative is what? False negative is 1 minus sensitivity divided by true negative specificity. What is the formula for false likelihood ratio negative? The formula for likelihood ratio negative is 1 minus sensitivity over specificity. Forget about this formula now. Forget about the false negative and true negative. That is just a thing for you to explain. Okay. Please remember, don't message me later on in social media that, sir, you told likelihood ratio negative is Fn by Tn. That is a concept for you to take. MCQ take home message is that what is the formula for likelihood ratio positive and negative. What happens in your real exam? See, right now you might be in the best understanding. Well, you might be so docile. You are so sweet and cute and docile that you are listening to me everything. And you are able to understand everything because you are at peace of mind. But in the real exam, you will be like all panicky. This is happening, that is happening. You will be all in a panic state and in anxiety. If I give you, tell me the formula for likelihood ratio negative, and I give you option as sensitivity over 1 minus specificity, specificity over 1 minus sensitivity, 1 minus sensitivity over specificity, 1 minus specificity over sensitivity. Now tell me. Then you are gone. You are gone. In your anxiety state, you will not be able to get the right answer, that the correct formula for likelihood ratio negative is, where is it? It is a 1 minus sensitivity over specificity. You will not get this understanding only when, if you understand that it is nothing but the false negative divided by true negative. Are you getting it? That was the reason for me to tell you this understanding. Otherwise, just forget this understanding. Take home messages, likelihood ratio negative is 1 minus sensitivity over specificity, and likelihood ratio positive is given by the formula sensitivity over 1 minus specificity. Are we okay with this? Now, if you have understood this likelihood ratio, that is the take home message. This is an important slide for you. If you understand this, now let us move to the next topic. We are going to talk about receiver operator characteristic curve. Receiver operator characteristic curve, ROC curve. That's a funny name. Why would somebody keep such a bad name, receiver operator characteristic curve? See, what happened is, way back in World War II, there were a lot of mathematics was involved and people were starting to be intellectually more advanced. So what they did was they built a radar, and on that radar, if they find some spot on that radar, right? So Germany is finding, France is finding, they'll have that radar kind of thing. And they find some unknown spot. They will check up whether should there be any air activity at that time. It was not there. So immediately they'll send their fighter planes and all, whatever they want to send, and just to find out that it was an artifact. It was in reality not there. So to find out the statistical point that what is the chance of doing a false positive and what is the chance of doing a true positive result, they started building this receiver operator characteristic curve. Very soon you'll understand. Receiver operator characteristic curve is a curve. So curve has to be between some axis. So you have a y-axis and you have a x-axis. X is always flat and y is always straight. So you have a x-axis and a y-axis. On the x-axis, that's a common notion. On the x-axis, we always take into account 1 minus specificity. And on the y-axis, you're going to take sensitivity into the account. Right? So wait over here. What did I say? 1 minus specificity and sensitivity. What was the formula for likelihood ratio positive? Likelihood ratio positive was sensitivity over 1 minus specificity. ROC curve is between what? It is between sensitivity and 1 minus specificity. So can I say that you are nothing? You are doing nothing. You are just doing likelihood ratio is a mathematical presentation of the ROC curve, or ROC is a graphical presentation of the mathematical formula called as likelihood ratio positive test. Are you understanding? So first I had told you all the things in a mathematical manner. So now I am going to show you the mathematics. So let us say there is a test which has a good sensitivity and a 1 minus specificity is also there. So can you tell me, if you understand this, which test is a good test? Test number A, test number B, or test number C? A, test number B, or test number C? Which test is the best test? Let me just make a little bit difference with A and B and C. Which test is the best test? Please understand, a good test, which should be the reasonable screening test, a test which is like A or B or C, a test should have very high sensitivity or a reasonably high sensitivity. So it should be more towards the top side of the curve, and the test should be more towards the right side or towards the left side. What do you want to say? A good test should be more right or the left. It should be more towards the left side. Why? Because what is this? This 1 minus specificity. What is 1 minus specificity? That's the false positive rates. So a good test should have lower false positive rates. So a good test should be top and it should be more towards the left side on a ROC curve. That is your MCQ number 1. So in this curves, like you have A, B and C, can you tell me which one is the best test you would like to pick over here? We would like to pick curve number B. Why curve number B? Because it has a reasonable sensitivity and it has a lowest false positive rate or 1 minus specificity rate. A is not a good test because it has low sensitivity and higher false positive rates. C is also not very good because it has very high sensitivity, but the false positive, can you see, is very high. So we don't want to use C also. So which is the best curve over here? We would like to go with curve number B. Are we okay with this? Sometimes examiner can confuse you that if you take X is to Y ratio, the X should be how much? 0 and 0, 0 and 1, 1 and 0, or 0 and 1 and 1. What is your best answer over here? So they are going to confuse you. So on X axis, you already know that X should be towards 0. And ideally, the Y should be towards 1. So which is the best answer? 0 and 1 for X and Y. Provided you know that X is what axis and Y is what axis. So you have done 2 and 3 questions over here, that how to find out which is the best test. Best test is top and left. X and Y axis they can ask you, and they can ask you which one is the best test, which is the more towards the upside and more towards the left side. Next type of MCQ, they can also confuse you on the ROC curve. They can ask you something like this, that can tell me which is the best test, test A, test B, or we can have a test C. We can have maybe a test C, something like this. Sorry. We can have a test A, test B, or test C. Which of the following should be a screening test? Screening test. Right? Which should be a screening test. Screening test is usually, we call the screening test as the first investigation of choice. You remember in many cases, we have many diseases. For COVID-19, you have the first investigation of choice. Then you have the gold standard investigation. Then you have the confirmatory investigation. For myasthenia gravis, you have the electromyography as it's one of the main investigations. For myasthenia gravis, you will have something else. For every disease, you have the first investigation, the best investigation, the next best investigation, which is the gold standard, which is the ideal. So many things are there. So we draw ROC curves for everything and then we find out. In this MCQ, what is the screening test of choice? What do you think? Mark A, B, or C? So answer to be understood is very simple. The screening test of choice would be C. Why? Because it has the highest sensitivity. I agree. It has very high amount of false positive rates. We agree to that, but it also has the highest sensitivity. That is the first level, which should be the diagnostic tool. Which should be the diagnostic tool. Diagnostic means which should have very high specificity. So now the highest specificity, that means the most confirmatory test should be most confirmatory test. Most confirmatory test should be which one? The most confirmatory test should be test number B. Why? Because B has the highest specificity. Why highest specificity? Because it has the lowest false positive rates. Are you able to get it? So please remember that based on the ROC curves, we are going to define which test is used as a screening test. So technically speaking, this would be our screening tool, and this could be used as our diagnostic tools, even depending on like what is the sensitivity and specificity. Although many of you might argue based on my drawing over here that A test should be taken as the ideal because it has a good sensitivity or specificity. But anyways, that's just a point of discussion, right? So please remember, theoretically speaking, B will always win over A in terms of diagnostic capacities because it has the lowest amount of false positive rates, right? So with that, for this topic on receiver operator characteristic curve, let's move ahead and let's talk about the next topic. We'll be talking about the false positivity determinants. So if you have this table like this, you have a disease plus, you will have a disease minus, you have a test plus, you have a test minus, you have a true positive, true negative, and you have a false positive, and you have a false negative. Can you tell me MCQ over here that I'm going to ask you is under what situations, right? Mark the word. Under what situations can you ever have a higher false positivity? You will say, very nice. I know the answer. That the false positivity can be high. So I want you to focus on this point. I told you which is the serious error. It's the false positive. You, from now onwards, every time you walk in the clinic, you trust me, at the back of the mind, you will always think of false positive, false positive, false positive. Why? Because if the person is tested positive, he can be a true positive, he can be a false positive. So it's always a dilemma for a clinician, for a radiologist, for a pathologist, for anybody. They will always write down that line, please correlate clinically. Nobody takes their own headache. So the test is positive. It is important to find out whether he is true positive or false positive. So anyways, that was on a lighter mode. Coming back to chances of how to increase the false positive or under what situations the false positivity may be high. This cell, the false positive cell in this whole box, the false positive cell can be high if the cells move like this. If the cells move like this, that means this false positive will be higher, right? Or there could be another situation where the false positivity, the cells would drop down. So now the false positive is again higher. Are you understanding this? That is, the false positive the line will come down. So now in this box, I'm going to play with the box. So the playing of the box is either the cells would shift up and down or the cells can shift left and right. Right? So if they are shifting left and right, that will be scenario B. If they are shifting up and down, that is scenario number A. In either of the cases, the false positivity may change from the normal conventional, what you have already learned. So now you are moving at the next grade. You are somewhere in the grade 8 or grade 9 after understanding the kindergarten in the previous module. So now what is this model now? Let us talk of the model number A. In this model number A, the lines have come down. So what has technically decreased? Can you tell me? The true negatives have decreased. If the true negatives have decreased, so technically this scenario is somewhat related to low specificity. Are you understanding this? So that means I will have high false positivity in what situations? I will have high false positivity in the situation of low sense specificity. In the situation of low specificity, I hope you all agree with me. Next MCQ. If you're moving the table left and right, what is decreasing? Please mind it. What is decreasing? I do not want you to say it is the sensitivity which is decreasing. That is the most common wrong answer. That is the most common wrong answer over here. Try understanding. Let us say that this is 70, this is 30, this is 82, this is 94. Calculate the sensitivity, bache. Can you please calculate the sensitivity over here? That will be 70 over 100. That is 0.7. Now let me just shift this cell like I did it in that side. So let us say this comes down to 7 and this comes down to 3. So the other side you get 82 plus 63 and you get 94 plus 27. That is what is going to happen because this table is fixed. So the number of the population is fixed over here. Simple. So now you have moved here. So what is the sensitivity? It will be same 7 by 10. So what is the answer? 0.7 again. So please mind it if the table, mind it, what I'm saying right now. Look at me right now, please look at me. That if the table is moving like this, the proportion of people out of the total people, the proportion of true positives out of the total disease, even if you move the cell like this, the proportion will remain same. So sensitivity never changes like this. So sensitivity will not change like this. So what are you going to have in hand? What is decreasing? Something is happening. Do not answer PPV also. I'll tell a little bit later that answer is not PPV. I have just kept that PPV, your answer, in my pocket. I know that doubt will arise. So what is decreasing technically? If you understand, if you remember the first word, the total number of, I told you the total population is fixed. What is decreasing, bache? The decreasing is the total D plus. That means what is decreasing? It is the prevalence which is coming down. Can you beat that? The disease has become more rare, more people are healthy and less people are diseased. So it is the prevalence which is coming down. So in case of low prevalence also, you will start having higher false positivity rate. So that means in case of low prevalence, you will start having higher false positivity rate. Right? So can you remember that? So please remember, lower prevalence will lead to high false positivity. Lower specificity will also lead to high false positivity. There is a third scenario. You need to just cram that because I cannot explain you. And it's not required at your level. please remember that there is a chance that you will also get high false positivity because of higher sensitivity. What happens is that sometime there may be higher sensitivity, higher true positive. So in those situations where you have high sensitivity, in certain situations it might be linked with the higher false positive also. But of course, you remember my rule number 2, I'm not supposed to cross the tables. But in certain situations where you have very high sensitivity tests, in those cases also, if the disease slightly changes in prevalence, you might start experiencing a higher false positivity. So anyways, that's an indirect answer. The MCQ for you, the take-home message from this slide over here, the concept that I want to build in you is, if you get a single best answer, the high false positivity is due to low specificity. That should be your best answer. Higher or high false positivity is because of low specificity. That is your answer choice number 1. In case this is not there in the option, please mark low prevalence. That should be your option number 2. In case these both are not there, then you go to that indirect phenomena of high sensitivity. But high sensitivity, please mark it. It is with reservations. It does not happen all the time. It is not mathematically derived. It is only seen in certain situations where there are differential prevalences of that diseases and different categories of the disease exist. In those cases, we might have carrier stages, we might have subclinical cases. Many things are determining this. But please mind you, with the reservations, I am saying high sensitivity will cause high false positivity. If you get a single best answer, which is the single best answer, which please remember, high false positivity is due to low specificity, direct mathematically proven answer. I don't need to explain you again and again this. This I have shown you that how did I derive this answer. It's there in front of you. We don't need to argue on that. So please remember, high false positivity is due to low specificity. Second best answer is low prevalence, and it can be an answer that is high sensitivity. If it is a multiple choice MCQ, all 3 are correct. You cannot deny any of them. If it is multiple answers are correct, all 3 you need to mark: low specificity, low prevalence, and high sensitivity. So with that, you cover this topic on false positivity as well. Let us go to how to calculate the PPV calculations. So now, to understand these PPV calculations, you need to understand 2 concepts over here. First is, what do you mean by probability and what do you mean by the odds? What do you mean by the probability and what do you mean by odds? Then we will talk about details in the probability. So first is, what do you mean by probability and odds? Probability, in very simple English mathematical language, probability means the chance. Odds is a ratio. Odds is actually a ratio. It is the chance, again, the number of times the event is likely to happen, divided by, or in the ratio, number of times the event is likely not to happen. So number of times it is happening divided by not happening. That is what is odds. I'll tell you an example, so probably it'll be easy for you. Let us say that me and you are playing Ludo game. So we have the dice kind of thing, so which has 6 faces, 1, 2, 3, 4, 5, 6. Let us say me and you, we are playing snake and ladders or Ludo. You say that we will start from our home, right? That home area is there. So you will start from your home only if I get a 6. What is the chance of getting a 6 on the dice at first time? What is the probability? The chance or the probability of getting a 6. How many faces are there? 6. So what is the chance you get a 6 out of the 6 faces? That is 1 by 6, right? The odds of getting a 6 is 1 by 5. Are we getting it? What is odds and what is probability? They both mean chances. But chance is actually a probability. It is always expressed in decimals. Can be expressed in percentages also, but technically we always express the probabilities in decimals. That is, the chance would be 1 by 6. If you multiply it by 100, that's also fine. But technically speaking, the chance would be 1 by 6. And odds is the ratio. Let us say that you say, though, no problem, we will play easy game. You either take 1 or you take 6. What is the chance you will get a 1? Then you can come out of the house, or you get a 6. So the chance will be how much? 2 by 6. What is the odds right now? It will be 2 by 4. Are you getting it? So this is what is the concept of odds and this is the concept of probability. But please remember that probability can be calculated by odds. If the odds we give to you divided by 1 plus odds. And odds can be calculated by, and odds can also be calculated by probability divided by 1 minus probability. So if you have very much extra time, take a calculator and do the probability and odds gaming over here. You will get the same answer. So in case we are asking you to calculate odds, you calculate this way. In case we ask you to calculate probability giving the odds, you calculate it this way. Next is now getting into the probability. Let's go ahead and see what is inside the probability. We can either have a pre-test probability or we can talk of something called as a post-test probability. Let us say a 50-year-old male enters into your OPD with features of weakness and malaise and weight loss and so many things. You're suspecting diabetes, okay? So if you suspect diabetes, you check his HbA1c and you check the fasting plasma, blood glucose and so on, and you repeat it. You found it to be high and you repeat it, and finally you label this patient as a diabetic patient. And you start this patient on oral hypoglycemic agents. So what is the investigation you had used? The investigation was fasting plasma, blood glucose level. Based on that, you divided the person as diabetic and non-diabetic. Now, my question is that what is the chance? Listen very carefully. What is the chance that a person is a diabetic before you do the investigation? So the chance that this 50-year-old male, he was actually diabetic before even we do the investigation or the screening test, don't you think, what is that chance? That chance will be nothing but the prevalence of disease in that community. If the chance is 10% or the prevalence is 10%, what is the chance that you are diabetic? What is the chance I am diabetic? It's 10% because out of the whole community, 10% are already having that chance of disease. So what is a pre-test probability? It is nothing but the prevalence. Pre-test, before the test probabilities. What is the post-test probability? Post-test probability. So after you had conducted this investigation, what is the chance he is disease? Do you remember that? Out of the total tested positive, what is the chance that this person is diseased? What is this given by? This is given by the positive predictive value. What is positive predictive value? The probability of getting a person as disease if the test is positive. That is what is PPV. That is what it means as positive predictive value or the post-test probability. So post-test probability, if we ask you in sometime in the exam, just remember that it is nothing but the PPV. PPV is the post-test probability. Prevalence is the pre-test probability. Or in other words, pre-test odds is also related to prevalence. Post-test odds is related to post-test probability or the positive predictive value. If you understand this concept, now let me take you through a small MCQ over here. So if you look at the MCQ right now, the prevalence of undernutrition in our country is 20%. A new Shakir's tape was launched in the community with how much? 90% sensitivity and 80% specificity. 90% sensitivity, 80% specificity for undernutrition assessment. Now the MCQ starts. What is the probability that a child classified malnourished, that is tested positive, will be in reality malnourished? What is the probability of having disease if the test is positive? In simple words, what are you going to calculate? This question says you should calculate the positive predictive value, or we call it as a post-test probability. So now you already know that what is given to us. I'll just change the screen. What is given to us? Sensitivity is given. How much is the sensitivity? Sensitivity is 90%, specificity was 80%, and the prevalence they had given you of undernutrition in the area was 20%. So this they have given and they have asked you to calculate the positive predictive value. So for this, you already know that there is a table, right? You already know that what should be on the top. Please remember that on top we should have the disease plus, and then you have the disease minus, the test plus and the test minus. That's what you have. And in this column, you have the true positive, the true negatives, and then you have the false positive and the false negative. Are we okay with this? So now let us build a table and let us try to fill this table. So you have D plus, you have D minus, you have tested plus and the tested negative. Okay. There are 3 steps which you need to follow. Step number 1, use prevalence to calculate to calculate the total D plus. That's very important step, and that is the step which is going to define whether you get a correct answer in your exam or not. Because invariably you will get an answer in the exam, and that answer will be there in the options also. Because the examiners know that what mistakes you guys are going to do, right? So if you are going to get the right answer, please remember that you have to talk about the D plus as the prevalence. So what is the prevalence they have taken? The prevalence they have taken is 20%. So let us say that I assume any random number. I usually take 100. You can take your birth date. You can take your parents' birth date. You can take whatever date you want. Number you take, any random number. You can take any of your lucky number. I usually take 100. What is the prevalence? 20%. So 20% of that number is the same answer. So that's the reason I take 100. So the answer is 20. That will be the D plus, right? D plus will be equal to the prevalence. So step number 2. Use sensitivity to calculate the true positives. How will you use sensitivity? You already know that sensitivity is equal to true positive divided by D plus. So true positive will be equal to sensitivity into disease plus. That's what it is. So can I say that sensitivity is how much? Sensitivity is 90%. So it is 90% into 20. So 90% of 20 in simple words. It is equal to 18. So where should I write 18? 18 should be written over here because it is the true positives. So what is remaining? You remember the total is 20. So 18 minus 20 minus 18 will be how much? You derive this answer as 2. But you calculated what? You calculated this 18. Are we done? Next, step number 3. Step number 3. The step number 3 is use specificity to find out the true negatives. Because you already know that specificity is equal to true negatives divided by D minus. Or in other words, the true negatives is equal to specificity into D minus. Right? So let's fill it out. What is the specificity they have given? Specificity is 80%. So you take 80% into D minus. What is D minus over here? D minus you have derived. You will have derived this D minus. Why? Because 100 total minus 20. What is left out? 80 left out. So multiplied by 80. Multiplied by 80. That is what you have derived. So technically 80% of 80 is how much? That is 64. So you are just going to fill up this 64 over here, where 64 is your true negatives. So what is the thing that you will derive? Total is 80. Out of that 64 minus what is left out? You will have actually derived this answer 16. But what have you made? You have actually used 64 over here. Right? So given 3 things, that is the prevalence, the sensitivity and the specificity, you have made the whole table. Now can you calculate the PPV? Now, can you calculate the PPV? Answer is very easy. We will calculate PPV, that is true positive divided by tested positive, that is 18 divided by 18 plus 16, that is 34. 18 plus 16, that is 34, which will come out to be something around 18 half, right? 36 is 18. So it will be 52%, something around 52, whatever number it is. Something around 52 you will get, that is the positive predictive value of this particular test. This positive predictive value, this is a desi way. This is our own way of calculating. You do not find this in books. This is just my personal way, step 1, 2 and 3. This is not a technical way, but this is just a MCQ way to help you guys out. And you don't find these things in the books. In the books, what you will find is how to calculate the PPV. PPV is given by the formula called as Bayes law, Bayes theorem. Bayes formula, sorry, not theorem, Bayes formula. Bayes formula is given by the formula PPV is equal to sensitivity into prevalence divided by sensitivity into prevalence plus 1 minus specificity into 1 minus prevalence. This is the formula for Bayes formula for calculating the positive predictive value. In the same manner, you can also calculate the negative predictive value. You just replace sensitivity with specificity and prevalence is replaced with 1 minus prevalence. So what is the answer? Sensitivity to be replaced with specificity into 1 minus prevalence divided by sensitivity to be replaced with specificity into 1 minus prevalence plus 1 minus specificity is now replaced, like specificity is replaced with sensitivity. So 1 minus specificity will become 1 minus sensitivity into 1 minus prevalence will now be reversed and called as prevalence. So that is the formula for negative predictive value. If you remember this, very good, 3 cheers for you, and you will be the topper in the exam. But anyways, for students like me who are average students, we will trust this formula. So that's a way to calculate the positive predictive values when we are given sensitivity specific. Please remember that positive predictive value is dependent on, positive predictive value is dependent on sensitivity, specificity, and prevalence. You remember in the last discussion, I had discussed with you that false positivity, how does it change? And there I told you that I will talk about PPV in some time. Now it is the time. Please try to understand that PPV is not dependent on the false positive. The false positive rate and the false negative rate of the investigation. Let us say this is the investigation. This investigation will have its own false positive and have its own false negative. These false positive and false negative will determine the sensitivity specificity of this particular test. So every test, the innate capacity is the sensitivity and specificity, the false positive and the false negative. These all combine and will depend on the prevalence to find the positive predictive value. In other words, simple words, false positivity will determine the PPV. PPV does not determine the false positive. Right? So I agreed to you last time also that PPV may be changed in false positive, but in fact, PPV does not cause a change in false positive. If the false positive change, then the PPV is going to change. PPV is highly dependent. It is most affected by the prevalence. PPV is most affected by the prevalence. Do you remember that this table was there? If I move the table left and right, what is going to change? The prevalence changes. If the table is moving left and right, what is changing? The prevalence changing, and this causes the change in what? The PPV, NPV. Will it change moving left and right? Will it change the sensitivity specificity? What is sensitivity specificity? It is this over this and this over this. So if you move the table left and right, the sensitivity specificity will not change. But if you move the table up and down, the sensitivity specificity will change. But PPVs, NPVs will probably not change. Are you understanding this? So I told you I'm going to play with this table. So once you get into the table, if you see the table is moving left and right, the prevalence is going to change, which is going to affect maximally the positive predictive value and the negative predictive value. But if you move the table up and down, like you had seen before, right? If you're moving the table up and down in those scenarios, what is going to change? The sensitivity specificity will change, not the predictive values. Are you getting it? So please remember this concept that how the sensitivity specificity is going to change with the change in the table formulas. So for your MCQ exam, take home messages. PPV is dependent on sensitivity, specificity, and prevalence. Prevalence is the one which is most affecting the PPV. Please remember this. Will you remember this? The next topic you need to do is something about the null hypothesis and errors. What do you mean by null hypothesis? That's what is my question to you. What do you mean by null hypothesis? You remember in epidemiology, in case you have listened to my lectures in epidemiology, or in case you haven't, that's fine. Just a small thing that you know that there is group A and there is group B. To group A, we are giving some drug A and group B gets some drug B. And then we are going to check them again for A dash and for B dash. What design is this? This is a simple, if you randomize this becomes a randomized clinical trial. That's what we have done, or randomized control trials. Whenever we do research, mark my words, whenever we do research, before doing the research, we are going to generate a hypothesis, and that hypothesis is called as null hypothesis. What do you mean by null hypothesis? Please write down in big capital letters. What do you mean by null hypothesis? Null hypothesis means that there is no effect. Null hypothesis means that both the groups are same. Both groups are same. Whenever you start any research, you start with a hypothesis that you're not going to find the effect. That is what is null hypothesis. You started studying PSM with me. You should have started by saying the null hypothesis that nothing is going to happen. This fellow is also same as other people. So there's no change. That feeling of null hypothesis is called as a null hypothesis, and you have to start your research using a null hypothesis. Let us say I invented a drug. New drug which was invented was not invented like usage of new drug. Remdesivir was started in in COVID-19 patients, or you have some new monoclonal antibodies for COVID-19 patients. So let us say you invent a new drug for a particular disease, and who's going to test that drug? You or your company is going to test that drug. So once you're testing that drug, what is the main motive in the back of the mind? The back of the mind is, I want to test the drug to find the effect, yes or no. So what is your null hypothesis? Null hypothesis states that there is not going to be any effect. Both the groups are going to be the same. And of course, once you conduct the study, A is done, B is done, and of course, you are technically speaking, mostly we are going to find the effect. If you find the effect, interestingly, what are you going to do with the null hypothesis? That is what is interesting for us. If you find the effect, you are going to accept the null hypothesis, or you're going to reject the null hypothesis? Say. If you are going to find the effect, you are going to accept the null hypothesis or reject. Null hypothesis says that there is no effect and you found the effect. So wow, what are we going to do? We are going to reject the null hypothesis. Are you getting it? So technically what I want to train you is that while you do research, the null hypothesis can be accepted, can be rejected. What do you mean by accepting a null hypothesis? Accepting a null hypothesis. Once you accept a null hypothesis, that means there was no effect which was found. If you reject a hypothesis, that means the effect was found. Agreed? You agree to this? Done. Very nice if you agree to it. If you not, then you should rewind it and listen to me again. There is a science which goes ahead on that. There is a science which plays on this. The science is that in reality, trust my words, you did a research to find the effect, yes or no. You made a null hypothesis that there is not going to be effect. You do a research, you invent a drug, everything you are doing, you are not God, right? So you invent a drug, you find the effect, you only say whether null hypothesis is accepted or rejected, but the science is that behind your back, you might be wrong, you might be right. Null hypothesis in reality, this is what is reality. Let us say reality is behind the back, which you don't see. Reality, the null hypothesis could be true, it could be false. If the null hypothesis was in reality true, if the null hypothesis was in actuality, in fact, in reality it was true, that means what? Very deeper understanding. If the null hypothesis in reality was true, that means in reality there was no effect. That means you should have done a research not to find an effect. You should have done a research to find that there is no effect. So in other words, in case the null hypothesis was true, you should be accepting it. In case the null hypothesis was false, in reality it was false, that means in reality there was an effect. You should also find the effect and you should reject the hypothesis. In very simple words, I want to train your mind that null hypothesis can be actually true or false. This is actually, it could be true or false. You are human, I am human, we can accept it, reject it, we can accept it, reject it. We might do mistakes, we might not do mistakes. In case the null hypothesis is true, in case the null hypothesis is true, you should accept it, you should reject it. You should be accepting it, we already talked. If you accept a null hypothesis, which is true, there was no effect, you found no effect. What is this? This is okay, you go home, it's all good. In case the null hypothesis was in reality false, that means there was an effect between the drugs, there was an effect of the drug, there was difference between the two groups. You also say there is difference between the groups, so you reject your hypothesis. What are you going to do? This is okay, this is good. The problem lies that in reality, if the null hypothesis was true, that's the climax of the whole game. In reality, if the null hypothesis was true, you, by chance, by some external forces, you unfortunately reject it. If you reject a true hypothesis, you are going to land up into an error. Right? That's a mistake. Mistake is error. In case it was false, in case there was supposed to be difference between the groups and your study says there is no difference, technically you are wrong. Right? God cannot be wrong, right? Actual is actual. You can be wrong. So in case you did an error, this is also called as error. So how I have remembered which one is which one? Truth is always first. First is truth. God is one. That's how I remember. So truth is first. This is called as type 1 error. False is second. It is called as type 2 error. Simple answer. So in my exam, I am not bothered what the MCQ is saying. Accepted, rejected, what happened, not happened, left happened, right happened. Forget about this. You just find the word in reality, the null hypothesis was true or false. In case it was true, what error are you going to get? So just find this word. In case the MCQ will say in reality, the null hypothesis was this. The MCQ will say in actuality. These are the keywords. So search for these keywords in the exam. The MCQ will say these. Whenever you find these, if the null hypothesis they say that is true, what is the error you are going to get? If it is true, the error is type 1 error. There is no possibility of type 2 error in true hypothesis. If the MCQ says null hypothesis is false, what is the error you are going to talk of? It is type 2 error. There is no chance of getting a type 1 error in a false hypothesis. So in my MCQ exam, I have trained my mind to find out what is the MCQ saying. Null hypothesis true or false, and based on that, we are going to define whether it is a type 1 error or type 2 error. Let's have a look at one small MCQ now. So now the MCQ goes, a study was conducted. It might be confusing for you. So in case you don't understand this MCQ, you need to relate with this MCQ in your biostat section. So a study was conducted to find the effect of new drug on COVID-19 in a hospital-based 22 patient non-randomized trial. It was compared to a standard regime which showed a significant improvement in the experimental group with a p-value of 0.01 with 95% confidence limits and relative precision of 80%. So that's the reason I told you need to look at this MCQ from biostats perspective as well. Once you have completed this module and you did not understand this, please refer to the section where we discussed about p-values. However, under the laboratory situations, 2 drugs, that's what the important question is, 2 drugs did not show any significant difference of the effect. The researcher could have committed a alpha error, beta error, gamma error, false negative error, no error. What do you want to mark? See, try understanding over here. The wise student will not see all this. I can give you tens and thousands of examples. I can make this as 68% confidence limit. I can make this p-value as 0.001. I can make relative precision changes. I can make you do 20 somersaults in this MCQ only. But what I cannot change is this. What I cannot change is under laboratory situations, very important line. In fact, the most important line in this whole statement is this. Under laboratory conditions, the 2 drugs did not show any difference. So what did I tell you? Watch for the words in reality. Watch for the words in factuality. Watch for the words under ideal conditions. Watch for the words in laboratory conditions. So these means the real conditions. So under laboratory conditions, the 2 drugs did not show. In reality, the null hypothesis was true or not true. The 2 drugs in reality did not show any difference. What do you want to say? Null hypothesis was true or not true? So you just forget everything. Leave this whole thing. It's not required. It is all extra stuff that I had written. Forget everything. So what you need to remember is that under laboratory situations, these things. So what do you think of the null hypothesis was true or not true? The null hypothesis in this case did not show any effect in real life. That means the null hypothesis was true. And if the null hypothesis was true, somebody had told you couple of minutes back in this tablet module only, I only told you that if the null hypothesis is true, what error you are going to find? You are going to find type 1 error. That is what is alpha error. You already know. Simple as that. Even if you leave this whole question, you don't need to remember this whole thing. Forget this whole question. You need to see only one line, and a wise student will see only one line. That you need to find out these words in the exam, and you will be able to find out the answer. Anyways, let's move ahead to the next topic. Let's talk about comparing the cutoffs. My question to you is, what do you want? That the cutoff for a disease should be a low cutoff or it should be a high cutoff? That is what we are going to discuss. Let us say that this is the world. Earlier we had the box world, then we had a circle world. Now again we are at the box world. Let us say that this is the box world. In this people, there are some people who are diseased and there are some people who are healthy. Let us say we are talking of diabetes mellitus. So don't you think that there will be some people on this axis? Let us say I'm drawing the blood glucose. So if I'm drawing the blood glucose, don't you think that the diabetic population will be more towards the upper side? higher blood glucose it will happen. So these all are people I'm drawing. There will be very few in the down below, but mostly will be congregated. They will be gathered in the upper floor. And don't you think that the healthy population mostly will be in the lower side, but there might be one or two in the upper side also. That's how the world looks like? Answer is no. This is not true. How does the world look like? In reality, they don't live in boxes. Diabetic people staying here, non-diabetic staying here. It doesn't happen. In the real life, they are all mixed. So we have diabetic population hanging around here with one or two in the lower also, right? And you have the greeny people, which are the healthy people, moving around left and right. The greeny people will be moving around left and right, but majority will be in the lower side. They are all mixed. Is that how the world looks? No. That's not even way the world looks, because diabetic people are not red in color and the healthy people are not green in color. Nobody comes and says that I'm going red from green, right? They don't change their colors. In fact, we all are having the same, whatever color we have, brown color or black color, whatever color we have, we all have the same color. You are a doctor in this world and you have to decide which one is a red color, which one is a brown color. Where will you keep the first cutoff? Do you want to keep it at point A or you want to keep it at point B? You tell me. For the first cutoff, for a screening tool, please remember, for a screening tool, you want more people into the game. Beyond this, there will be maximum red people and you should keep a lower cutoff. For screening test, we keep a low cutoff. Even for diseases which are fatal, we have to keep a low cutoff. But mind you, I'm not saying that 100% it is possible. There may be some greenies which are on the upper side. And of course, there might be some red color people who are on the lower side. No test in this world can have 100% true positive, 100% true negative, 100 false positive, 100 false negative, or 0 false positive or negative. You remember in the start also I told you that no test will ever lie on the same line of God. There has to be some true positive, some true negative, some false positive, some false negative. It's a rule of system. That's how the nature works. So for a screening tool, we always keep MCQ, take home messages. Screening tool, you always keep a lower cutoff. And for fatal disease, you always keep a lower cutoff. So that is how you define the cutoffs. Next MCQ. How do you interpret these screening tools, or what is the way of interpreting what happens to the sensitivity or what happens to the specificity? So please remember that let us say that I give you an example first. Let us say that in your classroom, you all are young students, right? I'm also young, but of course you all are younger than me most probably. Let us say that in a student classroom in a medical college, I check your fasting blood glucose. If I check your fasting blood glucose, maximum of you are going to have 90 mg DGL. There might be some people right now listening to this video who are just about to flat, right? And there's too much, you're about to puke right now. Too much of screening is happening. But your blood glucose is 60, way on a lower side. You're about to collapse because you've learned so much. And there might be some people because they got tensed and learned so much screening and their blood glucose is now 180 because they were eating all the time. In anxiety, eating, learning screening. That's fine, but majority will be around 90. So that means that majority, maximum population is having a 90 blood glucose. If I take the diabetic population, maximum, I'm taking the diabetic population, right? Their fasting blood glucose, the fasting blood glucose of their diabetic population median would be, let's say 140 or 150 also. Very few will be there who have a fasting blood sugar of 100. Very few can also be with the fasting blood sugar of 240. But majority will be around 140. Am I correct? Now let me just mix these two curves. If I am going to mix these two curves, don't you think it will form something like this? That these were my healthy population and these were my diseased or the diabetic population. And in the healthy population, of course, we all understand that maximum were around 90. In the diseased population, we understand that maximum were around 140. Some could be even 180 and some in this could be 60 as well. Let us say that I keep my cutoff let us say that I keep my cutoff of the disease population as 120. So if you keep the cutoff as 120, what is going to happen now? That is what you need to understand. So what I have drawn is a probability distribution. These are probability distribution. There's just a teaser for you, because main probability distributions we will discuss in biostats. In case you have done that, very good. In case you have not, you will study that in biostats lectures. So right now, there's just a small teaser for you, and that is called as a probability distribution curves. So I have drawn probability distributions for diabetic population. If I keep my cutoff as 120, what is this population? Can you think and tell me? What are these greeny people? These greeny people are the healthy people. The red people are the diseased people. These greeny people who are healthy, in reality, they are healthy. Because of my cutoff, what are they? These are false positive, false negative, true positive, true negative. These are technically called as falsely positive. Why? Because they were actually healthy. Are we okay with that? On the other hand, in case, what are these? These were the red people. And because your cutoff is at 120, what are these? These are falsely positive, falsely negative. These are falsely negative. I hope I am correct on this. These are falsely negative. If this is falsely negative, on the other hand, you have falsely positive, you need to always, in the distribution curves like these, you always need to focus on false negative and false positive. If you understand this, let me take you to the next level and give you a small MCQ over here. The MCQ is something like this. Let us say this is the world, and you have some people who are diseased and some people who are healthy. So this is my disease, this is my healthy population, and this is my diseased population. Let us say that this is the cutoff that we already have. Let us say there is a new investigation which was launched. The new investigation goes something like this. And the new investigation in the disease was also something like this. So what we have over here, this is the old investigation which we were already having, and the new curves were formed with the new investigation. So let us call this as N. This is called as O. Okay. So now, can you tell me what are these people? These people who were actually healthy, and because of my cutoff, they are diseased. So these are my false positive. On the other hand, what are these? We already discussed. These are the false negative. These are the false negative. Now the thing is very easy. Can you tell me what is happening to the sensitivity and specificity? With the new investigation, what will happen to the sensitivity and what will happen to the specificity? What do you think? The sensitivity increase, the specificity decrease, or the sensitivity will decrease, the specificity will increase, or they both decrease, or they both increase? What do you want? They both increase or they both decrease? You have option A, you have option B, C, and D. What do you want to mark? I know many of you must have got it correct. Let me just explain to you what has happened over here. If I see this curve, the red color curve, can I say that the false negative, the quantum of false negative, this area, is lesser with the new investigation than the false negative with the bigger investigation, that is the old investigation? That is, the false negative in new is less than the false negative in the old. Are we correct? On the other hand, if I take the false positivity with the same principle in the new will be lesser than the false positivity in the old. If you understand this, you already know that what is false negativity. False negativity is the inverse of sensitivity or specificity. False negativity is the inverse of sensitivity. So if false negative in new test is less, that means it will have a high sensitivity. Are we getting it? In new test, the false negative was lower than the old test. So that means the sensitivity is higher. On the other hand, what is specificity? Specificity is the counterpart of false positivity is the counterpart of specificity. So therefore, if the false positive is lesser with the new test, what is higher? It is the specificity. So with the new investigation in place, what is going to happen? You will have a high sensitivity and a high specificity. So technically speaking, what you need to remember in your exam is whenever we give you a probability distribution curve like this, you just need to see the center part of the curve. You just need to focus on the center portion of the curve, and that is going to tell you what are the probabilities of the errors which are happening. Are we okay with this? So you just see the errors which are happening, and based on the errors, we are going to define what will happen to the sensitivity, provided you know that false negative is inverse of sensitivity and false positive is inverse of specificity. Once you have done this, let us come to the next topic, and talk about the combination of tests. So whenever we have, let us say, an investigation 1, investigation 2, investigation 3. In HIV you had SA1, SA2 and SA3. You have multiple tests. So many diseases will have multiple tests. So please remember, the take home message over here is that the combination of the test can be in two ways. You can have test 1 and test 2 and test 3 all at a single time. So if all the tests are done, if all tests are done at same time, if all the tests are done at the same time, what is going to happen if all the tests are done at same time? That is called as a testing in parallel. But if you do test 1 and then you do test 1 will be positive or negative, and then you find out whether we'll be doing test 2 that is positive or negative. And in case it is negative, only then I will do test 3. Only then I'm going to do test 3 which is positive or negative. So this testing where you have conditions applied is a conditional testing. It is called as testing in series. So that means I want to tell you that combination of test can be in two ways. Either you can have a testing in parallel or you can have a testing in series. Are we good with this? In case we are combining the test, then something will happen to the sensitivity, to the specificity, the positive predictive value and the negative predictive value. If you combine the test, if you combine them in series or if you combine them in parallel, then something is going to happen to them. Okay. How I have learned. What is my favorite alphabet? My favorite alphabet is P in PSM. My favorite alphabet is P, not the word P. It is the alphabet P. So wherever P and P meet, they go for P, they go down. That's how I have remembered. I know it's not a very nice thing to say, but that's how tacky it is. So parallel P, specificity P, positive predictive value P. P go for P, so it goes down. P goes down. Remember, P goes down. So that's how I have remembered. So that's my way of remembering. Anyways, you can have your own way. So if the specificity is down in parallel, the other things are up, like specificity in series will be up. The sensitivity, because the specificity is down, the sensitivity is high. And over here, if the sensitivity is high in series, the sensitivity is low. Talking of the positive predictive values or the negative predictive values, you know that the positive predictive value in a parallel is low. So that means the positive predictive in series will be high. And because PPV is high in series, the NPV is low, and NPV is low, the NPV is high, and so on and so forth. So what I have remembered for my exams is that I'm just sharing with you what I remembered. I remembered that P goes for P. So in parallel, I have remembered the specificity is down and the positive predictive value is down. That's all that I remembered. And based on this, I derived all things which happens in series or in predictive values and so on. So that is the take home message for you to remember. And if you have your own way, you are most welcome to use this. But this is the chart that you need to remember for your MCQ exams, that what happens to the testing in combination, in test in series and testing in parallel. So we come to the nerd corner. Nerd corner is some of the extra edge points. Nerd corner is some of the extra edge points for all those students who still want more. So I'm really happy that you have reached this part of the lecture, because it is difficult to reach till this point. So congratulations if you've actually reached till this point. If you want to learn a little bit more, you're most welcome to do that. These are nerd points. These are some extra points. What do you mean by R charts? R charts are nothing but the range charts. They talk about the range of a particular investigation. The range is telling you the precision, that how much closeness you get at the same time. So R charts will tell you about validity, and R charts will tell you about precision. If you get one answer, please mark these are reproducibility charts. These are range charts, and they will tell you about precision. Next MCQ. What do you mean by LJ charts? LJ charts are also devised on the same manner. You have a line, and based on that, we will tell that how many times you got the test near to the close line. So this close line actually represents the median line. It is considered as the actual value. It is considered as the actual value, and let us say the digital hemoglobinometer or digital some other big fancy machines, RT-PCR machines, LAM machines, these all these big biochemistry machines. So these all machines, we will do LJ charts for them. So there will be a median line which we consider as actual value, and we will see that how this test performed in this particular machine and what is the level of the points which they give, the results that they give. So LJ charts will tell you all the things. It tells you about the validity. It tells you about the accuracy also. It doesn't tell you much about the precision, but yes, it tells you accuracy and validity. If you get one answer, please mark accuracy for LJ charts. R charts are reproducibility charts or the range charts. They tell you about the precision. LJ charts will tell you about accuracy. Validity, every chart is going to tell you that whether they are answering in the same range or not. The range is there or not there, right? Next is, what do you mean by yield of a test? The yield of a test, it corresponds to the positive predictive value. It is also the diagnostic. It is also the diagnostic capacity of a test. Yield of a test is the positive predictive value. It is also the diagnostic capacity of a test. Yield or the positive predictive value, we already talked, is influenced by the sensitivity, specificity and prevalence. Yield is most affected by same answer. It is most affected by the prevalence of a test. So you have discussed 3 points. You have discussed point number 1, point number 2, and you have discussed the point number 3. Next, 4th point you need to do is, what is the diagnostic accuracy of a test? The diagnostic accuracy is given by how many times I speak the truth divided by how many times I speak. I know you must be confused with this. Diagnostic accuracy of a test is number of times you speak the truth, that is true positive plus true negatives, divided by how many times the test speaks, that is true positive plus true negative plus false positive plus false negative. Are you understanding? That is the diagnostic accuracy. But the diagnostic capacity is given by the positive predictive value, and you also learned about the R charts and the other things. Last point is point number 5. What is Youlden's index? Youlden's index is nothing but, it is a point which is calculated in the receiver operator characteristic curve. It tells you how far the investigation is away from the baseline. It tells you how far the investigation is away from the baseline. In very simple words, it tells you the utility of a screening test. It tells us the utility of a screening tool. It tells us the utility of the screening tool. So just remember 2 points about Youlden's index. It is calculated in the ROC curves, and the bigger the Youlden's index, the more better the test is, because it tells you the utility of the screening tool or the diagnostic tool. So with that, I think we have covered many points in the screening of disease, and I hope you must have enjoyed learning the concepts in screening of disease. With that, thank you so much for watching this whole chapter on screening of disease. See you in another chapter next time.